Good afternoon, Ms. Dempster, and good afternoon, Dr. Mumford. Mr. McIntosh.
Thank you, my lord. What I want to do is return to water. And I think probably what I'll do is I'll direct these two questions to Dr. Mumford and then see if Ms. Dempster has any comment. So, Dr. Mumford, to what extent do you think there needs to be an exceedance of a standard or guidance threshold before it's possible to decide whether that a water system in a hospital is contaminated or whether that contamination is widespread or systemic?
I think if there were that really comprehensive standards, then that would be a reasonable thing to say. But because there aren't comprehensive standards, only for Pseudomonas and Legionella, that makes it really difficult to make that as a broad statement.
In a circumstance where, as there were in 2015, no national standards beyond Pseudomonas and Legionella, how should a hospital trust or a health board notice that there is a risk of its water system becoming contaminated or has actually become contaminated?
So I think that's about having good reporting systems and good governance systems and ensuring that the water safety plan is in place and is followed, and that the reporting to the water safety group and beyond is as it should be, with the right membership of that water safety group to include people who will be able to identify risk, and whether that's actual risk related to the water itself or risk that is becoming evident within the patient population, and ensuring that there is appropriate escalation processes in place.
If there were appropriate escalation processes in place, would one see the evidence of those within the minutes of the water safety group?
I would hope so.
Right. Ms. Dempster, do you have anything to want to add to either of those two answers from Dr. Mumford?
I just think it's not just about the testing, is it? You alluded to the water safety plan, but the compliance with like the LA legislation is there, isn't it?
Yes.
And
So
see that
what would
safe
you
water system regarding L8?
What would you expect to see in minutes of a water safety group if a hospital has carried out an L8 risk assessment?
I'd expect to see that as, I don't mean a standing agenda, but that would be sort of crucial to your water safety is your compliance with L8 and then any actions that you need to take or maintain.
What I want to do now is move on to ventilation, because am I right in thinking that you've relied on the reports of Mr. Bennett and Mr. Poplet? I'll direct the question initially to Ms. Dempster.
Correct, yes.
And what I want to ask you is a series of questions that imagine that each of you were standing in the shoes of your equivalent number, so that you, Ms. Dempster, were the lead ICN of the health board or the lead ICN in a part of the hospital at the time, and you, Dr. Mumford, were the lead ICD or a sector ICD at the time. And so the first scenario is, I'll start with Ms. Dempster, is in 2015, it became clear that isolation rooms in both the adult and children's BMT wards were not fitted out as some IPC clinicians and treating clinicians expected them to be. And you've seen the material of how the adult BMT service returns to the Beatson, but the paediatric one proceeds with bone marrow transplants happening. Do you have any issues, Ms. Dempster, as if you were standing in the shoes, what they knew then? So without the benefit of hindsight, with the decisions that were made by infection control nurses at any level in that summer of 2015 when those two decisions were made?
The decision to proceed with
Proceed in the children's
With
and,
the bone marrow.
and to return at the Beatson.
no, I don't have any problems with that because I'm, again, would have assumed, you can never assume, that somebody would have made those, if you're thinking of a child needing a bone marrow transplant, for example, that that clinical decision would have been made for in the best interests of that child and the risks that they face by probably not having the bone marrow transplant. And I'm sure that the clinicians would have been involved. When I say the clinicians, I mean the child's, hematology oncologists. They would have been involved in that process. They wouldn't, if the risks were known, they would have been discussed and a decision made.
In respect of the, I think there's an email, Sandra Devine visits. She noticed there's no HEPA filters. She reports this back. So if we make the assumption that the infection control nurses, both in the Children's Hospital and for the whole health board, realised there weren't HEPA filters, there were holes in walls, there weren't sealed ceiling lights. They seem to have been concerned. Were they right to be concerned?
Yes.
Dr. Mumford, if you put yourself in the shoes of either Dr. Peters in respect of 2A or Dr. Inkster in respect of 4B or Professor Williams as lead ICT, what should have been the correct steps to take once it became clear in 2015 that these two specialist facilities were not specified as clinicians expected, ignoring for a moment any contractual issues?
So, the first thing to look at really is the patient risk, and you would want to do a full multidisciplinary team approach to doing a full risk assessment for those patients, and a risk-benefit analysis of whether they should stay where they are or move, or in the case of the child, whether the transplant should be done in Glasgow or somewhere else. And that would have to involve, as I said, the multidisciplinary team, so microbiologists, infection control team, the clinicians on the ground, the estates, to talk about what the possible mitigation could be in the short term, and what the possible mitigation would be in the long term. And once you had made those decisions about the patients, you would then go on and look at the estates issues and how you would, what was, again, the art of the possible in how far can you mitigate the issues that you have, whether that was lack of HEPA filtration or unsealed ceilings or lack of positive air pressure, to get the best possible outcome going forwards and what that work would look like. And that would be, it wouldn't be like half an hour sitting down around a table. That would be something that would take several weeks, if not a few months, to get in the granular detail that you would need it to be able to inform those future decisions.
To what extent would you accept that that's quite a high standard in terms of detail for a hospital reacting just after it's opened? It's a busy time. Is it reasonable to expect such a big and detailed exercise to be carried out?
Well, the risk assessment for the patients, absolutely, because patients come first and you have to make sure that they're safe. So absolutely you should do that risk assessment and the benefit risk analysis to decide the placement of the patients and how you proceed. From the estate's point of view, what work is possible in the short term and longer term, it strikes me that not having attention to some of those details is what got the situation arose in the first place. So absolutely, it shouldn't have been the case, but having the position of where they were, they had to get it right to follow it up.
If we go back to the question I asked Ms. Dempster, is that if we think about the decision to go ahead with bone marrow transplants that summer, is that a decision, I mean, obviously you're looking at it from a distance of time, but knowing what they knew at the time, do you have a difficulty with that decision?
I don't, because there's, although I haven't seen the risk assessment itself, we've seen documentation saying a risk assessment was done, and those conversations, that multidisciplinary team conversation went ahead. And if that's the decision that's been taken in the best interest of the child, then I don't have a problem with that.
And what about the decision to return the adult service to the Beatson? Do you have any issue with that as a decision?
Well, again, it's a risk-benefit discussion, isn't it? And, you know, we weren't there. It's very hard to put yourself into that conversation, but I would imagine that, you know, if the facility wasn't what it should have been and actually presented a greater risk to the patient than moving back presented, despite the lack of ITU facility, then absolutely moving back is the right thing to do.
You'll have heard there was some evidence from Dr. Inkster about, I think it was November, December 2015, when she was asked to sign off a return of Ward 4B from the Beatson, and she didn't do so, and it didn't actually return for a couple of years. Knowing what you know, and I appreciate you've only heard her evidence, Professor Williams, Sandra Devine, Dr. Armstrong, you may have heard everybody. Do you have any difficulty with her approach to risk at that point?
I think she was put in a really difficult position because she wasn't given the information that would enable her to be confident about making that decision and taking the responsibility on behalf of the board for making that decision. And I think it's a lot to ask of an infection control doctor to make that kind of decision.
Because at that point she had a couple of sessions of ICD.
Yeah, when you're not provided with all the information. I mean, for me, the position of the ICD is to advise somebody higher up, an executive, of this is the evidence, I've analysed it, this is my report on it, these are my recommendations, would you like to make a decision? It shouldn't be a decision that is made at ICD level.
Right. I want to move on to another group of decisions that are happening in 15. They're not even decisions, they're more sort of commentary. We've heard repeated evidence and we've read computer communication that there's no guidance for the specification of a bone marrow treatment ward for its ventilation system in SHTM0301. I do respect the fact you're not ventilation experts. And so I'm asking you to come at this from the perspective of infection control nurse and infection control doctor rather than specialist ventilation expert. I wonder if we can look at SHTM0301 Table 1, which is in Bundle 16, Document 5, page 483. And the reason I've shown this to a number of witnesses, and I absolutely appreciate there's lots of technical material in here, but there is a phrase which I'd like to get your perspective on from your two professional backgrounds, and that is neutropenic patient ward. And so starting, I suppose, with Ms. Dempster, what would you understand to be, from your perspective of an infection control nurse of some experience, to be a neutropenic patient ward?
A ward where patients are nursed to neutropenic.
Would they have to always be neutropenic?
No, I should have probably caveated that, because there will be groups of patients who we would know the risk, the haematology oncology patient group, transplant groups. Vastly all of those are going to be immunocompromised or neutropenic for most of their stay. You might be neutropenic and end up in a different part of the hospital because of a different condition, for example. So it's not going to be...
So you might be neutropenic and end up in ITU?
Yes, yeah. Or I might fall over and break my leg, and I need to be in... Probably not a very good example. You know, you need to be in a different part of the hospital for their specialty. But there will be cohorts of patients who would meet the criteria, if you like, of being in a neutropenic patient in a patient ward.
I'll just ask Dr. Mumford the same question. I'll come back to you, Dr. Mumford. What would you understand to be a neutropenic patient ward from the perspective of an ICD?
I would expect it to be a ward where the majority of the patients were neutropenic for the majority of the time.
Right. Ms. Dempster, I want to ask you, I've got 3 questions for each of you.
Okay.
And I'll start with, perhaps I'll alternate and see what happens. Knowing what you know, Ms. Dempster, about the mix of patients in the Schiehallion unit through all the work you've been involved in, what is your view about whether the whole of 2A, not just its isolation rooms, would, to your understanding, be a neutropenic ward?
Yes, I believe it would be.
Why is that?
Well, the children and young people on that ward would probably come out of their rooms as well and mix in different areas, go off to there was a room we saw on there where the teenagers would go. So there were other areas apart from your room.
Can you think of a reason why Ward 2A would not be a neutropenic patient ward?
No.
Dr. Mumford, do you have anything to comment on that particular question?
No, I agree.
Dr. Mumford, knowing what you know about the nature of the adult bone marrow treatment patient cohort, the ones who returned to the Beatson and Efferin Ward 4B, what's your view about whether Ward 4B as a whole, and not just its isolation rooms, would be a neutropenic ward?
I think the same thing applies. That a neutropenic ward is a ward. It's not just patient rooms, and it includes the other areas because inevitably patients will come out of their rooms, whether that's to go into a clinical room or to have a procedure on the ward or whatever. But
Or just even to walk up another corridor?
yeah, or just walking down the corridor. I mean, they will. It should all be treated as one unit.
Now, more difficult is, I wonder if we can look at the document, Dr. Mumford. Well, first I'll ask Ms. Dempster, do you have anything you want to add to that question about 4B?
No.
We look at document, which is Bundle 27, Volume 7, Document 19, page 375, which is an email from Dr. Hart to Dr. Inkster on 6th of December 2018 about Ward 4C. 27, Volume 7, Document 19, page 375. Yes, and so if we would go on to the next page, we would see the question that Dr. Hart has asked. And so Dr. Inkster asks on the 5th of December, hi Alistair, when we decanted the paediatric hemat oncology took the opportunity to review the ventilations, there are some concerns. A number of issues have been identified which have implications for other wards on the site, one of which is 4C. I have been asked a question from Estates, highlighted in the email tomorrow. I need to give it some thought. Can I check, first of all, you have patients with the following risk factors in Ward 4C? And the first one is recent history of neutropenia. And then if we go to the page 375, we get the answer, yes, we do constantly AML and all patients. Now, conscious, Dr. Mumford, that you're not a clinician who treats bone marrow transplant. Have you ever had adult hemato-oncology patients in your hospitals?
Yeah.
What's your view on whether, given what Dr. Hart is saying, albeit in 2018, Ward 4C is a neutropenic ward within the definition of that we've seen?
This is a very high bar that they are suggesting, I think. I mean, neutropenic patients go home.
Right.
Quite often. So they don't stay in hospital. Right? I mean, clearly there are added risks of just being in a hospital. But in that kind of scenario, you might want a few rooms for your more profoundly immunosuppressed patients. But I wouldn't say that constituted
a neutropenic ward.
A neutropenic ward. And that AML and all patients is actually, according to the PS at the bottom, it's all acute lymphocytic leukemia.
So it's not all the patients.
It doesn't say all, it
No.
says acute lymphocytic leukemia.
Well, I suppose I should learn that. Right. Ms. Dempster, anything to add to that?
No, I agree with.
We've heard evidence. So this is going back to the role play of being the lead ICD and the lead ICN. That in May 2016, Dr. Inkster learned that the whole of the hospital, outside specialist ventilation rooms, was running at 3 air changes an hour rather than 6, as required by SHTM 301, and she received an email from Mr. Parry about that, which I think you've seen. She produced an SBAR, and that SBAR is of June 16. It's bundle 4, document 11, page 52. It's a single page. Can I just check that you've both read this before today?
Yeah.
Yes.
Yep.
Now, we've heard from a number of witnesses that there's no other risk assessment beyond this SBAR of the 3 air changes hour rate. Professor Steele was the clearest. Starting, I think, with Ms. Dempster, to what extent are you comfortable with this being a sufficient first stage response to this discovery that there's only 3 air changes now?
I don't think it does provide a response to that across the whole of the site.
What's wrong with it, and what would you be expecting?
It's not looking at the risks of any of the patients who might be at risk. This is just, the way I'm reading this, it's patients who are coming in who might have an infection themselves, that they're looking at how they prevent that transmitting to other patients.
And that's what we see in the first paragraph of
Yeah.
assessment. You're nodding again.
Yes, sorry, I'm sorry, yeah.
So this doesn't address patients who don't yet have an infection.
No.
What would you require to do? I mean, I'm conscious that people like Mr. Hoffman and
Yeah.
Mr. Poplett and Mr. Bennett have all got opinions on this, but just in terms of process, what would be the necessary process that you would see required to be done to react to this news?
I would have thought, well, if I'm playing that scenario, I would have looked at all of the wards that we have in the hospital and the patients in them, and looked at the categories to see whether they met the 6 air exchanges or the 10 that would be recommended.
So a patient
Like a
placement?
like a picture of the whole picture, what was happening everywhere and what we would expect to see.
Because you would expect some wards for it to be less of an issue than other wards,
Yes.
and some wards for it to be more of an issue.
Yeah.
Right. I'll come back to you with a specific question. I'll turn to Dr. Mumford. Is there anything, what's your view of this as a sort of first response by the lead ICD to this discovery?
I think it's incomplete. I mean, I agree with Linda, this just addresses those patients, as she says, with airborne infections in these rooms. So it's all about airborne infections, and it's about patients who've come into the building with an airborne infection. And I think it's from that point of view, it's incomplete, and it should be a broader document, or at least a comment on it to say, I'm only including these in this. There must be supplementary work on vulnerable patients and what the implications of that.
And how would the sort of work that you were envisaging here compare to the sort of work that you talked about when we discussed 2A and 4B in 2015?
Well, as Linda said, you need a risk assessment of every area, what the ventilation looks like, what it should look like, and the potential mitigation of that, and what more you could do.
No,
Sorry, can I just?
Sarah.
I think it's very hard from just one page of A4 to know where was this going, who it was for, and what was the reason.
Because this is a point you generally have about SBARs in the class.
Yeah, so this one is discussing a very specific case about, there's an investigation going on, and we're looking at this group of people with cystic fibrosis. So this seems to be a small I don't mean a small, it's quite focused SBAR, which then would have presumably, if you've only just found out there's only 3 air exchanges across the site, there would be a whole load of work that would follow on from that.
Well, Dr. Inkster gave evidence that in the recommendations, certainly 2 to 7 would probably find their way into SOPs, standard operating procedures.
Mhm.
My question for you is, how would it be possible to operate a door closed policy in a hospital this size? How would you do it?
Well, it's even more challenging when you've got 100% single rooms, isn't it? So it's challenging enough sometimes if you've got a 20-bedded ward with 6 side rooms to try and make sure that doors are kept closed. So it would be difficult. And there are times when you do need the door open, you do need to observe somebody in the room, or somebody's frightened in the room, or claustrophobic in the room. Perhaps they're a risk at falls. You couldn't, I don't believe, apply a blanket policy to say every door will be shut without thinking of the person, the patient in the room.
So as an infection control nurse, how do you go about convincing members of the hospital staff to do things that are, in terms of time, inconvenient, that you require them to do? Like, you couldn't convince them to wash their hands, presumably you have to tell them about the risk.
Yeah.
So how do you tell them to shut the doors?
Well, I think it's them understanding the need to shut the doors, but this door shutting is relating to the people in the room who've got an infection.
So you could explain that quite easily.
Yes, you could. And you could easily say that there are times when the doors need to be open, and we've all would have seen many times that patients could not have the door shut. And then you would do some kind of assessment, say, is this the patient a risk of infection to everybody else? Have they got TB, for example, and the door definitely must be shut? Or can we leave the door open? Or is it so important the door's got to be shut and the patient perhaps is confused or disorientated that they actually need somebody to stay in the room with them to make sure they're kept safe? So it's a challenge.
Is there anything you want to add to that, Doctor?
Well, one of my hospitals is a 100% single roomed. So we've come up against this issue, and we have a risk assessment, because when you tell nursing staff on the ward that all the rooms have got to stay closed, say you had a norovirus outbreak, then sometimes you might say, shut all the doors, keep them all shut. The first thing they do is go, oh, I don't think we can do that. And they are instantly worried and concerned. So a risk assessment enables them, as Linda was saying, in certain circumstances to leave the door open safely. So they work their way through the risk assessment for those patients that they're concerned about and determine whether or not they can close the door or leave it open. There's all sorts of nuances around it, like, you can open the door during times of low traffic in the ward. So overnight, maybe you can leave the door open because there's not very much movement, so there won't be as much air movement. But it is a really challenging problem in that multi-room environment.
What I want to do now is think about the positive pressure ventilated lobby rooms. And the air change rate across the general wards in terms of management of patients. So we had a hospital that appears to have been designed with 30-something positive pressure ventilation lobby rooms, and the rest of the rooms, all 3 air changes an hour, single rooms. Are there any issues that arise in terms of simply managing that hospital, in terms of dealing with potentially unusual events or unexpected infections that arise because you've got a balance between 3 air change an hour single rooms and 10 air change an hour potentially PPVL rooms? Dr. Mumford?
Yes, is the short answer. The longer answer is that you have to have some sort of method of prioritising your patients so that those with the greatest need end up in the better or correctly ventilated rooms for their need. And it's really complex, and you have to have a really good method of managing your beds in order to do it.
And how would you compare you presumably saw emails and you've heard evidence of witnesses of what was going on in terms of working out what the rooms were in 2015. How does that compare to the ideal you're discussing?
It makes life really, really challenging. So, and you know, every hospital goes through this to some extent because most hospitals would have a very limited number of side rooms. So therefore, you prioritise the patients that you put in them. And there's always a lot of work involved in that, usually from an infection control team, in identifying who's in which room.
Yes.
And identifying their need to be in that room. And also identifying the point at which they can come out of that room if somebody of greater need is admitted to the hospital. So it's a complex thing, and I imagine somewhere the size of the QUH, it is much more complex.
In terms of managing the fact that you've got most of the rooms sitting at 3 air changes an hour and very small numbers of rooms above that, are there any sort of events that hit a hospital where that becomes a problem, where there aren't lots of 6 air change an hour rooms available that you can think of from your practices?
Well, I mean, there was COVID, but COVID rapidly developed into a, doesn't really matter because everybody's got COVID scenario. But you could have a community-based outbreak, or you could have a hospital-based outbreak where you wanted to protect certain patients.
So if it was a hospital outbreak, what sort of infection will we be talking about where air change rates becomes an issue?
So something like norovirus, rotavirus, any of those airborne diseases, that would become very important for the most vulnerable patients who you wanted to protect.
And they'd be in 3 air change an hour rooms.
Yeah.
Ms. Simmons, anything you would like to add to that before we move on?
No, I don't think so.
Right.
Thank you.
I'm going to deal with Mr. Bennett and Cryptococcus tomorrow, so I'm not forgetting it, but just for the purpose, for a reason of housekeeping, I'm going to do it tomorrow. What I want to do now is move on to infection patterns, your second source in your report. Now, you've discussed it in some length in your report. There's been some additional material that's come out in evidence. What I wanted to do was to ask a few questions about the general methodology of Mr. Mukherjee's report and your involvement. We've done the choice of infections, but just general methodology, and then see if there's anything that you can help us understand in other bits of work and his work. I'm working on the basis, please tell me if I've got this wrong, that as infection control professionals, you can understand the work of epidemiologists. Are you both happy with that idea that if an epidemiologist starts putting slides up, you will understand what they're talking about most of the time?
Most of the time, if I didn't, I would ask them.
So in terms of Mr. Mukherjee's work, he chose a particular methodology. Did you both have involvement in developing that? I don't know who wants to answer that question.
We discussed it. We relied on him to come up with the epidemiological analysis and the methods by which he would want to do that. But we then discussed it with him so that we were clear that what he was doing would get to the point that would produce something useful.
What I'm keen to find out, both of you, is why you think it was appropriate or important to compare the Schahalian cohort with other paediatric hemato-oncology units elsewhere in the UK. Ms. Dempster, is there a particular reason you felt that was the right comparison to make?
Well, because it was right to compare with other. Sorry,
To compare with other
them with adults or something. Is that what you meant? Or
yes,
just,
exactly.
Yeah,
I mean,
yeah.
why pick that comparison?
A similar population. We couldn't say they were definitely the same type of population, but we selected from the list of NHS trusts in England and Wales those units that had bone marrow transplant units in them.
Would there have been any advantage in comparing the Schehallien unit cohort with, say, a large teaching hospital with an accident emergency department,
No,
or a regional cancer centre for adult patients,
no,
or a district general hospital?
no.
No. You didn't think about comparing the Schehallien with other hospitals in Glasgow, for example?
No.
No. Is there any particular reason?
Because it would be a very, very different patient cohort. It was trying to find a similar cohort of patients with the similar risk factors and treatments.
Anything you want to add to that? Or?
No, I think that's.
I think you've already answered that question, and that one too. Do either of you have any view on the debate which seems to have broken out about whether the correct denominator should be admissions or occupied bed days, having heard evidence from a number of witnesses? Dr. Mumford, do you have any view about the utility of either as the denominator?
I think that there's probably arguments in both ways. I can understand why Mr. Mukherjee felt that admissions was the right one because it gave it used the turnover of patients and the number of patients who were going through the unit, and therefore the risk to individual patients. But also occupied bed days also gives you a kind of quantum of risk because it's the whole patient admission is counted in the denominator. So I think there's pros and cons to both methods.
Do you have any comment on his evidence about the difficulty of getting occupied bed days from other hospitals?
I'm less sure of that because I haven't got experience of a large number of hospitals and how they calculate their occupied bed days. But if you asked me to do it in my hospital, I would just be able to make one phone call and get it because we have a electronic bed management system, which I think is not uncommon. So we have that patient admin electronic system which allows you to calculate that relatively easily.
Right. Okay. You state in your report on 33 almost certainly don't say that at 33.2. I'm just going to have to find out where you've done that because that's definitely a wrong reference. You don't have a paragraph 33.2 in your report. So I shall come back to that later when I've checked this. If we can look...
it's in the direction 5.
Yes, it is direction 5, thank you, sorry. If we look at your direction 5 document, that's 24, volume 6. And it's 33.2. You describe in the second half of that paragraph, Mr. Mukherjee has demonstrated a significant difference in the infection rates per 1,000 admissions between the Schehallien unit and the 4 English comparator units. I wonder if we can just show you the document that was put up for the first time on Mr. Mukherjee, a single page, which has this final figure with an additional line added, and we can talk about this. So is that reference at 33.2 in your direction 5 response a reference to the green line in his report or the dotted purple line? What line is it a reference to?
It's the dotty purple line.
Do you understand that that only includes overnight cases in 2A and overnight cases in 6A?
Yes.
And not day cases?
Yes.
So is that sentence entirely correct? because it's not covering, the dotted purple line doesn't include the day admissions.
So I don't think I appreciated that the comparator unit included both day and inpatient admissions.
So Mr. Mukherjee recalculated and produced what is now the magenta line, the bottom of the figure, which shows the overall Shahanian rate per 1,000 admissions, including day and night admissions. Do you have any view about how would you describe that result in comparison to the comparator units? Would you continue to describe it as significant, or would you give it a different description?
Well, it still more than doubles multiplies the risk by 2.5 at the peak. So I would say that was still, and doubles it in 2018. I think that was probably still significant when you're talking about the high risk population.
Ms. Dempster, do you have anything to add about that? Or?
No, I agree. Yeah.
Now that you've heard Mr. Mukherjee's evidence, do you have? Are you sticking by what's in 33.2, or would you change it at all? Because obviously you refer to, at its peak in 2017, the Ward 2A rate, which was more than 16 times the average rate for the comparator units, albeit that includes day cases.
Well, clearly, perhaps the numbers need to be amended, but I think the other question to ask before you come to that conclusion, or any conclusion, is around the proportion of day case to inpatients in both units, and I think that would probably give you more granularity. I know we haven't necessarily got the data, but I want to ask more questions, I think.
But you can't, because we haven't got the data, right?
So yeah, so there still is, in my mind, a significant increase, but it's not of the order of magnitude that we previously stated.
In Mr. Mukherjee's evidence, he talked about why he chose annual totals rather than monthly totals in this figure. And my recollection is he felt that the human mind finds it hard to see a chart where you show monthly totals because it will bounce up and down a lot. With that in mind, I was proposing to show you a lot of monthly charts and ask you if you had any thoughts arising from them. I wonder if we could compare this, so we can keep this around and not get rid of it, and look at Bundle 7, Document 6, which is at page 214, which is the October 2019 HPS report, and I go to page 230. Hopefully, we have figure 6, not figure 6, sorry, figures at the top of the page, which is the SPC chart using the environmental, including enteric group case definition for HPS data from July 13 to December 19. So that's the blue-green line at the bottom of that chart. Do you see anything conscious that there's this monthly variation of difference or similarity between the changes that are happening over time in that figure and the one in the previous figure, which perhaps we can flip back just to help you reach a conclusion? Albeit, so this one doesn't show pre-15, the other one does. If we go back again, is there anything going on that might be a similarity or a difference?
So if you lean back and have a look at it, squint a bit, you can see that there is a step change in the rate of infection in 2017, 2018. And there's still some very high months in 2019. And you've got some data exceedances as well. So yes, there is a definite increase, although it's difficult to see because you do have that bouncing around of the data.
And the way this is presented, presumably we've had evidence that the centre line is only found from data in the chart itself. It's not from an external baseline.
Sorry, I
The
missed.
centre line is not based on an external baseline. It comes from, it's the average of all the positions in this chart, according to
Yes.
Dr. Imrie. If we could just look at the earlier HPS chart for environmental group, which is bundle 7, document 5, page 194 at page 210. So this is the environmental group. Now remember, this was a group that was slightly smaller than your group when we looked at it this morning. And it has drawn out the two areas in circles. But is there anything that seems to be similar or different to the conclusions from Mr. Mukherjee's report about infection rates?
I think you see the same pattern again of low levels in 2015 going into 2016, and then it's starting to rise with higher levels in 2017 to 2018.
Now, Ms. Dempster, anything you want to add to that?
No, I agree with that, yeah.
This is a question which I should have asked Mr. Mukherjee about, so it may be that neither of you want to comment on this because it might be out with your area of expertise. But the second chart, which was produced in this report, deals with the whole children's hospital. And there are 3 moments when the data for this group goes above the upper line. They're the red diamonds at the bottom of the chart. Can we draw any conclusions, Dr. Mumford, from seeing changes in the rate of these environmental infections across the whole children's hospital?
Well, I without knowing what those infections actually are, but you could put forward a theory that they could be patients who are on the PICU or other high-risk patients elsewhere in the hospital.
But you'd have to look and drill down.
But yeah, but there's definitely, in order to determine whether they are just kind of general, if you like, patients rather than the high-risk patients, you would have to know.
What I want to do now is to look at the presentation by Dr. Kennedy and Ms. Rogers to the IMT in 20th September. So if we just go back to the document that Mr. Mukherjee produced that we're keeping to one side, hold that thought, and then we look at Mr. Mukherjee's addendum report, which is bundle 21, volume 1, page 771. So this is his rate of infection in 2A only per 1,000 occupied bed days. Now he described this as a roughly tripling of infection rates. And so we've got those 2 bits of information. Let's look at Dr. Kennedy and Dr. Rogers. So that is bundle 27, volume 13, document 13, page 77. At page 85. Now, we obviously look at the top of that, we see, should we worry that this is all gram-negative blood cultures? Dr. Mumford.
I don't think you can draw any, I mean, you can see that the rates go up.
Yeah.
But whether or not you need to worry, I think is a...
Because the reason I'm interested, and please shoot me down if it's necessary, is what I noticed is that the left-hand column of this chart is a rate per 1,000 occupied bed days. And it shows, as I think Mr. Mukherjee interpreted the numbers, if not the significance of it, quite a low rate until late 16. Then it steps up and starts bouncing around, to my eye, 6, and then drops away a bit. And given he's identified a rate for just 2A of 6 per 1,000 occupied, I did ask, is there something going on here that we can draw a comparison? Do you have any views about whether this is useful?
Well, again, you're back to monthly rates. So the troughs are as important as the peaks when you're comparing the annual rates with the monthly rates.
I see. So we shouldn't worry about this chart too much, or should we? What can we draw from this chart?
I think you can draw that there has obviously been an increase in bloodstream infections, but I don't think you can say more than that.
Okay.
Sorry, could I just get that from you again, Dr. Mumford? you can say that there is
an increase
an
in
increase.
infections, but you can't. Sorry, I've forgotten what I said myself now. Sorry. You can see that there has been an overall increase in the number of positive blood cultures, but you can't say any more than that.
I wonder if we can look, please, at Ms. Dempster, do you have anything you want to add about this?
No.
No. I wonder if we look at page 122 of your original report. That's bundle 21, volume 1, page 122. And so you at 5.2 suggested that the Schehallien unit is in effect used as a proxy for the hospital as a whole to identify the overall risk. Now, I think you've thought about this because I asked you that question at a consultation last year. But I wonder if you can expand on your 5.12, expand on your meaning of as a proxy. What do you mean by as a proxy?
So I think so your Schehallien unit patients are your most vulnerable patients out of your whole patient cohort in the RHC. And because they're vulnerable for a long time and they can be exceptionally unwell. So you can use that group because you can you can identify the risk in there, and then you can be reasonably confident that the risk elsewhere is not going to be higher than that. So that gives you a kind of ceiling for your level of risk because these are your most vulnerable group of patients.
So is proxy quite the right word?
Possibly badly worded. Yeah.
What would you think might be a better word to use there?
I don't think there is a word. I think I probably would have phrased it as I've just stated it.
Can you help us, Ms. Dempster, about how you see the Schehallien unit being in relation to the whole children's hospital?
I think it's as Sarah said, and I'm not a very good wordsmith, so I'm sure I'm not going to come up with the best sentence to say that. But the decision was made with that sentiment in mind. That's why we chose it.
Does it sort of amount to the idea that if there is a problem with the water supply, it will exhibit itself first in this cohort?
Yes.
Now, I want to move on to the views of others. And this section is a little eclectic, as I think it was in your report, a little eclectic. And what we can start with, I want to cover whole genome sequencing and its utility, laboratory practices, selection pressure by meropenem, Ms. Devine's appendix to the GGC positioning paper, and Mr. Bennett's report on Cryptococcus. I don't imagine we'll get to the end of this by the end of the day. I wonder if we can turn to whole genome sequencing, which you cover in your report from paragraph 9.130 in page 161 through to 9.149 on page 163. Now, you seem to be saying in this report that the utility of whole genome sequencing, in your eyes, determines to some degree on the reliability or extensiveness of environmental sampling. Have I got that right?
Yes.
And I want to check a couple of things that's been suggested I should put to you. That NHS GDC have carried out more water testing, colony picking, whole genome sequencing. Well, I'll put it a different way. Are you saying that GDC should have done even more of this stuff at the time? More water testing, more colony picking, and more whole genome sequencing?
Well, the whole genome sequencing, as I understand it, that was done by Professor Leonard and Dr. Evans, they use the same source material.
Right.
For both papers. So there was an awful lot of water testing done subsequently.
So when you say subsequently, after what time?
Well, after the samples that they used, and even before, and that where the organisms were not saved and the whole genome sequencing wasn't done.
At the time.
Yeah.
But to be fair, it probably
Or
couldn't be
even
done.
subsequently. So there weren't in order to say that I've tested the whole water system and I've done whole genome sequencing on, you need to test everything. You can't pick.
So what's
but
your
choose
basis
what
for
you-
that observation, that you test everything?
Because if you have a multi-organism contamination, for want of a better word, of your water system, when you do the culture of that, you will have multiple strains of the same organism and lots of different organisms.
And is there research to support that assertion?
That was the reality of the situation, wasn't it? It's not a matter of research. When they cultured the water, there were multiple different organisms in water samples, and we know from research certainly that multiple different strains exist within water systems. It's not a static population. You get variation, and so unless you can, in order to say there's no link, you need to identify all of those different strains and all of the different organisms and all the strains of those organisms, and then test them all. And because they was doing a lot of retrospective work, so they were taking samples from stored organisms.
These are samples taken in 15, 16, 17.
Yeah, they were looking at stored organisms, and without clarity about how those organisms had been chosen to be the ones that were stored. And Professor Lennon's paper in particular mentioned that, you know, some of the organisms that he cultured up were different from what was on the label on the tube. So there was some discrepancy also in whether or not the labelling was accurate. And so because you didn't have that almost the chain of clarity around how the tests have been, well, we know what the water process was, but how those organisms on an individual basis have been chosen, how many of them, was it just one of each morphological type or was it more? And then storing them, and then it was kind of, as Professor Leonard described, the luck of the draw, which ones they managed to find in the archive of organisms. So to make a deduction when you do the whole genome sequencing is very difficult, because he didn't do thousands of organisms.
Because at the moment they seem to be doing quite a lot now. Would you accept that?
I haven't seen it. I don't know that.
So can I ask you to look at a document which I don't know whether you saw, I Miss Dr. Walker saw it. It's in Bundle 18, Volume 2, document 105, but it's particularly at page 459. And it's the standard operating procedure, page 459. It's in the water. So this appears to set out, if we look at the bottom of the page, what was being done in June 22, and it lists all the samples that are to be taken. And if we slowly plod through the next few pages, that's too far. So we plod through until we get to page 4565, and then we look at the flowchart that follows in. That's the governance water. Have you had an opportunity to look at these sort of documents in the bundles? If we go back to say page 459 itself. So they're obviously doing some measure of monthly, weekly tests for various different things, and they have rules about where they're to be taken from. Would you accept that they're doing testing now at a higher frequency than before, and over a wider range of organisms and TBCs than before?
Absolutely.
And are you aware of any health board or trust in the UK that's testing with this sort of frequency?
I don't know.
Does your hospital in Kent test with this sort of frequency?
No, because we do follow a standard protocol, and then if we find anything of concern, we will. So we do our augmented areas mostly, and then if we find anything of concern, then we increase our testing.
So when you would increase,
it's not this kind of testing.
in the sense it's not as much, or it's more?
It's not as much, and it's not as prescribed.
So if they're doing more and in a prescribed way than your hospital, how is it reasonable to critique what they did, their sampling strategy, in the question of whole genome sequencing?
Because this isn't what they were doing then.
This is what they're doing now. How would you respond to the view that since Dr. Kelly was appointed authorising engineer and Mr. Clarkson became the authorising person, the GG has learned a lot and implemented new ways at a higher level of intensity to adequately sample and test water? Would that something you'd accept?
Well, I mean, looking at this SOP, you would have to accept that.
Yeah. Ms. Dempster, would you be able to help us whether hospitals that before you retired that you were involved in were testing water at this level of intensity in England?
I couldn't say.
What connection do you see, Dr. Mumford, between the amount of water testing being done at GGC and the history of the water system? Are these two things related in your mind?
You would assume so.
Why?
Because, if you've had huge problems with your water system, it would make sense to increase the amount of testing you were doing until you were confident that those issues were resolved.
What I want to do now, thank you, is to turn to your addendum report, which is Bundle 21, Volume 1, page 773, and to the topic of PICs used in laboratory methods. I'm assuming, Ms. Dempster, this isn't your thing.
No, I'd like to say it's Dr. Mumford's thing.
I wonder if you can take us through the approach you've taken on page 776. Because I think we could do with a little seminar on PICs, because we've had a lot of evidence from Professor Leonard, Dr. Redding, a little bit from Ms. Lee, Dr. Lee, but subsequently we've had statements following Professor Leonard's evidence from Dr. Inkster, Dr. Peters, I think a couple of other people. And obviously we've got to read those statements and understand them. So when you're taking a water sample simply to identify things for the purposes of treating the patient, what's your objective in terms of how many PICs you take or how many samples you take?
So I'm going to challenge you slightly, because you would never take a water sample in order to
Okay, well, I'll rewind it.
Lead you to how you were going to treat the patient.
So if we go back to a patient sample.
Yeah.
So imagine you've got a patient sample, you're treating the patient, you have a suspicion they have disease, microorganism X. And then in comparison with that, you're taking a patient sample and you want to do whole genome sequencing. Is there any difference in the objectives, the methodology, the approach to how many colonies you pick between the two?
So in a blood culture, usually you would only have one organism. It would be a single organism which was causing the infection. Sometimes you get them mixed, but most of the time there is a single organism. And you, under those circumstances, you can just pick one colony to save and send for whole genome sequencing.
So let's imagine that you've got your infection in your ward, you're worried about a couple of cases, so you start doing environmental samples. Is there a difference? How many picks or samples would you grow of water samples to, say, find some Staphylococcus that you suspect it might be there because it's in the patients? How would you do that?
So the way you culture it, if you're looking for a particular organism, is to use selective plates or so on, so that you can identify which colony is the Staphylococcus or which colonies are the Staphylococcus. Now, because we know that in water you can get multiple strains of the same organism, and that's partly due to biofilms and the diversity that develops within them. You couldn't just pick one colony of your presumed Staphylococcus. You would have to pick more. And that's partly to assure yourself that they're all the same, but it's also partly to say, well, actually, we have got some different strains here. And so we need to be comprehensive in how we take them. So if you've got a few colonies, you should take all of them. If you've got many, 100 colonies, that would be too many, and you should take a representative sample. And I think the literature that I've seen, which is very limited on the subject really, is probably somewhere around 30 colonies.
Do you discuss this actually over the page on 3.9? On 3.8?
Yeah, so you would pick more to be sure that you had got samples of each strain, or to assure yourself that it was a single strain.
I suppose the final question is that if you're trying to prove a negative,
Mm-hmm.
and I want to make sure that we as lawyers don't make a mistake because we think something's similar to something we're used to and read across when it's the wrong approach. So as lawyers, we might, for example, imagine there's a crime scene and there is various pieces of evidence that suggest that someone's been there. That's an eyewitness. Some mobile phone cell tower data. I don't know, an item has been found in that person's house. And well, there might be a trial, but there's no fingerprints. No fingerprints have been recovered. No DNA sample has been recovered. As lawyers, I suspect we would be surprised if someone argued, my fingerprints aren't there, my DNA is not there. That's conclusive proof that I didn't steal the valuable gold vase that you found under my bed, for example. That's a legal way of thinking about it in a different scenario. And I might suggest it's something to do with the proof of a negative is harder intellectually for us. The absence of evidence is not evidence of absence, as we would call it. Is this the same sort of method of thinking that's appropriate to the discussion of you proving using whole genome sequencing to prove the absence of connection, or have we misunderstood?
I think that there are different circumstances. So if you had two patients who had the same, say they both had a Pseudomonas in their blood culture, it was the same species, it was both of them were a Pseudomonas aeruginosa, both of them had the same antimicrobial sensitivity pattern. And you thought, well, maybe they're connected. Maybe they've either got it from the same place or one of them's given it to the other. If you do whole genome sequencing on their organisms, you can absolutely say, yes, they're the same, or yes, they're not the same. And if they're not the same, then these two cases are not connected with each other.
Right.
With water and the environment, because it's so diverse and because it's very easy to missed something, and it may be that a biofilm has broken down and sent a shower of Pseudomonas down the pipe, and then it stops again. So you can't be sure, you can't prove a negative. You can prove a connection. This patient has got this whole genome sequence. This bug found in the water has got the same sequence, therefore there's a connection. But what you can't do is say, I've done a couple of water tests, I've picked everything, it's not there, therefore there's no chance that this water has caused this infection.
Going back to the two patients, if you have two patients, or I think there may be an example where there are four patients in the same room or similar rooms over a short period of time, and they seem to be the same strain, and they seem to have the same resistance patterns, and there's some suggestions they've used the same shower, and that's all been developed by infection control staff. But you carry out a whole genome sequencing, you discover they're not closely connected in that SNPs basis that we've had discussed with Professor Leonard and Professor Wilcock. Does the idea that the fact they're not closely related and therefore there's no link, isn't that reliant with the idea that there is only one infection source? Because could it not have been the case that all four received a different Stenotrophomonas strain from the shower as that biofilm broke down?
Yes. They could all have acquired their infection from the water, but what they didn't do was acquire the same strain from the water or acquire it from each other.
And what level of rigor would you need to apply to your sampling to take four unconnected whole genome sequencing level cases and say they are not connected to the water at all?
You couldn't.
Why?
For the same reason that you can't exclude a connection by testing the water. So if you know that you have got a Pseudomonas in the water, and you know that you've got 4 patients with a Pseudomonas, even if they're all different, you can't say that none of them have acquired it from the water.
And this is because of the diversity of the organisms in the water, right? What I want to do now is to move on to laboratory practices. This is back to your Direction 5 response, Bundle 21, Volume 4. Now it's page 22. So it's page... No, I think I've done that wrong. Give me a second. Volume 21, Volume 5. At page 131. No, this is not right. Sorry, I misunderstood. If we go back to Bundle 21, Volume 4, Document 5 at page 22, this is the GGC response to you. And you answered a question that arose from this. So do you see that there's a heading that they've inserted, implied failures in infection prevention control laboratory management, and there are 3 paragraphs that follow, and they make a specifically strong response to your report. And then they also provided us with a large number of SOPs and policies. Now, these are, I'm not going to go to them unless you want to, Bundle 27, Volume 17, Documents 12 to 28. And then in your response, if we go back to I don't think you've responded directly to their criticism because you didn't have the SOPs at this point in your Direction 5 response. And I wonder if you had the opportunity of looking at their SOPs that they've supplied.
I have.
Do they change your views about laboratory control and management that you expressed in your original report at paragraph 9.133?
So
which is on page 161 of volume 21, volume 1.
the comment I made specifically says in this paper, which referred directly to Professor Leonard's paper. It was not a global criticism of laboratory practices at GGC. It said in this paper there has been no standardised methodology recorded, and that was the case.
Yes, so this is not a criticism of the way that GGC run their labs. This is criticism, in essence, of Professor Leonard's paper.
Yeah.
Right, could you just take me back over that?
Yes, I managed to make complete haulicks of that, my lord. So if we just stay where we are.
Facility with 3 documents, which I was
If we stay where we are, my lord, we're on bundle 21, volume 1, page 161, paragraph 9.132. The paper by Professor Leonard and Dr. Brown recognises the limitations.
Yes.
And the next paragraph says, in this paper, there's been no standardised methodology recorded for taking samples, labelling or cultural organisms from the water and drainage samples. Samples taken over several years by an unknown number of people. This brings variation to the process of collection of samples, and so on. We then go to bundle 21, volume 4, document 5, which is the GGC direction 5 response.
Right,
Paragraph.
just take it slowly, because the right. So it's paragraph 28.
Well, 26 to 28 of their GGC response.
I mean, the word that sticks out there at 27 is the word egregious. So I want to ascertain whether we have dealt with that.
So they make their criticism, and no doubt they can deal with this in submissions, and I want to just deal with it in evidence, is that this paragraph deals with paragraph 9.133. So there are earlier criticisms about the failure of GGC in paragraphs 26, 27, which you've dealt with in your direction 5 response, and I don't need to revisit. And then paragraph 28 is targeted at the paragraph that we've just looked at, my lord, in the original report, 9.133. And so we jump back. The response here is that NHS GGC laboratories are UKSAS accredited and operate according to strict SOPs, with all patient and environmental data being obtained and managed with accuracy and integrity. And what Dr. Mumford, I think, was saying was that the criticism 9.133 is not targeted at the laboratories as a whole. It's merely at what is described in Professor Leonard's paper. I mean, to be fair, Dr. Mumford, could it be that you are slightly criticising the laboratories because Professor Leonard was only able to use the material laboratories retained and marked and labelled?
Well, yes, but it's a limitation of his paper, and I think he acknowledges that it's a limitation of his paper. So I was criticising the fact that he was that he did not include any methodology or even refer to the fact that there were SOPs in place. If he'd said, you know, the specimens were collected in line with the SOP, whatever it was, then I couldn't have criticised, but he didn't. He just said, you know, we went back to the archive and we pulled these organisms out, and didn't have then anything which you would expect in a scientific paper to see.
Right. And you've obviously seen the SOPs that are in place.
Yeah.
Now you've reviewed them. Are you able to provide any commentary about what your view is? You can take this off the screen. What your view is about the current SOPs that are in place in the
So we sent several SOPs which change over time. So several versions of similar SOPs, and you know the laboratory is a UCAS accredited laboratory, and because that accreditation means that they have to have those SOPs in place which are in line with UCAS standards. And that has been the case over a number of iterations that we were sent of those policies. So I have absolutely no problem with their SOPs.
Could it be the problem isn't actually the lab or Professor Leonard? It's that the samples that he was using were taken for a different purpose.
Probably.
And the water samples, well, we've heard David Watson from DMA Canyon as our first witness, and others talk about the change that water sampling techniques changed over time. And so the water samples were taken for a different purpose, were sampled by the laboratory for a different purpose, and whatever the reason they retained what they retained it for a different purpose.
I'm sure that's true, yeah.
And for the patient samples, that maybe is less of an issue because you can get away with retaining one.
Yes.
But they actually didn't retain all the samples, as I think Professor Wilcox took us through last week. Of the patients.
Yeah, so that's what I think Professor Wilcox found, but I would have expected that they would have. If you have a positive, I would certainly, the laboratory that I've worked in, if there's been a positive blood culture, then you retain a sample.
But in any event, some of them weren't used. So, I mean, I'm putting words in your mouth, but I wonder whether you think it makes sense, is that Professor Leonard is effectively working with the material he's got, created at a point in the past, and he has to do the best he can.
Yes.
And you then come along and say, well, that's not good enough, but to a certain extent, he can't do better.
Well, yes, and it was recognising that that was the situation, and so it was a comment on what had been done.
Right. What I want to move on now is to the topic of selection pressure. No, before that, sorry, I've got another question, which I've been neglecting Miss Dempster, and therefore I feel she should be asked some questions. We were provided with the current IPC process framework by the board, which is effective from December 23, which is Bundle 27, Volume 17, Document 28, page 315. And there's been some discussion about whether this is similar to or different from the National Prevention and Infection Control Manual, Part 3. And I'm conscious that you're an expert in the processes of a different jurisdiction. But just from your perspective, having read this document, is this different from the National Prevention and Infection Control Manual, Part 3 in Scotland?
I looked at this alongside the published manual, and they're very similar. But you couldn't, as a health board alone, just use the National Infection Control Manual. You do need some local information and detail to adapt your processes locally. So
yes, because you need your own instance.
This is like a template. This is what the ideal is. Then you're going to say, actually, you know, ours isn't done that way. We report it to the governance committee. There's variation. So even if you're using the manual, you use the manual as your framework, I believe, to operate locally.
So if we look at this page, for example, a different health board would have a different outbreak plan.
Yeah, that's, I refer to the NHS XYZ outbreak.
And they might have a different lead manager. They call it a different thing.
Yes, yeah.
If we go to the next page, so this is, do you see this as effectively a localization of the national manual from your perspective?
Yes.
If we go on to page 317, I mean, one of the problems I've certainly found personally with reading the manual is it's very loosely phrased, but then I'm a lawyer and it's written by infection control professionals and perhaps that's a different standard. But on this page, there doesn't appear to be a requirement to record a decision not to hold a PAG or an IMT. Now, it may be that that's actually done in medical records, I don't know, but is there anything that's significant about the fact that there's no requirement to formally record a decision not to hold a PAG or an IMT?
I think if you go to the next section,
Next page.
it talks about you're either filling in some concern. It says all assessments, regardless of outcome, must be recorded.
So you read that as
As you would record.
you would record them.
But
Okay,
you
that's,
didn't escalate to a PAG.
so that's a misunderstanding on my part. That's
But
helpful.
then that's, I'm looking at with that redacted, so I don't quite know what that line is. So.
If we go to section 2.5, which is the next page over, I wonder, Dr. Mumford, is there anything of interest in section 2.5 about environmental sampling, given our conversation previously about, and also various other people's evidence about data around environmental samples?
Personally, I don't think it needs an ICD to make the decision whether or not an environmental sample needs to be taken, because that could be anything. That could be a surface swab of a table. It doesn't have to be.
Dr. Mumford, I'm
I think you're a little
Sorry,
bit too quiet.
sorry.
having difficulty hearing you.
Sorry, I was saying that I don't think it necessarily needs an infection control doctor to make a decision to do environmental sampling. And because it could be something as simple as a surface swab, it doesn't have to be air or water, which is more complicated. And so I think, again, that's kind of maybe lacking in detail.
Who else would you imagine making such a decision?
Well, an infection control nurse
What about a microbiologist?
or a microbiologist. But an ICD in this context is a microbiologist.
Well, I suppose
aren't they? But
we're conscious there's evidence in Greater Glasgow of there being microbiologists who aren't ICDs.
yes, but if it was a Saturday morning of a bank holiday weekend and you wanted to do a sample, then you would want to take that decision, wouldn't
Right.
you?
I think it is important to help with the issues around identification of the lack of identification of where samples have come from. So it makes it very clear we need to know what room you're in, and they've all got some kind of unique identifier. Was it the wash hand basin? Was it the basin? So I think it helps to describe far better that you need all this detail to then track back to say the sample was taken in, side room number X from wash hand basin.
Thank you. I wonder if we can go on to section 3, reporting and governance. Now, I think both of you have heard or watched evidence from Dr. Inkster about her decisions along the way around decants, around water changes, and the interaction with the executive group. And you, I think, will be aware of her evidence that early in the water incident, she raises with Dr. Armstrong, she says, the idea there should be an executive control group to somehow for her to report to. With that in mind, I wonder if we can look at part 3 and particularly a weekly report requirement to the GGC senior management team. And over the page, the reporting of escalated red, amber assessments, then summaries of instances to reported to the acute clinical governance committee, and then further summaries to the clinical care governance group for assurance. And if we go to the next page, that's the summary. Now, does this policy, in your views, properly position the infection control doctor or an IMT chair in the structure so that when he or she makes a decision, it's clear what their remit is, what the decision can be, and who is responsible for making decisions as to risk? Does this provide enough detail?
I don't think it does. I mean, there's clearly lots of reporting in lots of different directions, but I think that the ICD doesn't have that direct access to the most senior subject matter expert always, and reporting through the infection control manager, who may or may not know anything about infection control is a very difficult reporting line for me. I would find that very, very difficult. And it wouldn't be ideal because you lose your expertise along the way of that. So if you have your expert who is, and we know that the infection control nursing team don't feel that they are expert in water and ventilation. But then you have your infection control doctor who has some expertise in those areas as they pertain to infection control. And yet the reporting line takes away that direct expertise.
Do you mean that someone with expertise is reporting to someone without the expertise,
yes.
who then reports to somebody with no expertise?
Yes. So you end up with, you could end up with a situation where you've got slight Chinese whispers, but you also lose that ability for the executive level to directly question the person with the knowledge. So it's not as rich a conversation as it could be in your escalation. So you escalate a problem, but it doesn't necessarily mean that the person at the top of that escalation understands what the problem is.
Is that entirely fair? Because we've seen a lot of email exchange in the period when she was lead ICD, between Dr. Inkster and Dr. Armstrong about particular moments of importance.
Yeah.
Where information seems to be flowing between the two of them. I mean, it's not doing it through a formal structure, but it is flowing.
But that's the point, isn't it? It's not through the formal structure. And that informal route hasn't been the most effective route. It's there because you need to get that message through, because Dr. Armstrong's there as the executive lead for HAI, and you've got your infection control doctor who needs to get to her, but actually the governance reporting route is not that.
So should have we been seeing that level of detail in the reports to the AICC, in the BICC, and those sort of committees? Is that what you're saying?
Well, the few minutes I've seen from those committees have been very, very brief, 1-2 liners on something which could be described as quite a significant event. And those committees are at such a frequency that they don't lend themselves for urgent action.
Right.
They're a governance assurance route or reassurance.
They're for these reports that Mr. Walsh has talked about reporting on national targets.
Yeah. So, and I know that if we go on to a little bit further down, we have a rapid escalation, big red arrow, but it doesn't describe what that rapid escalation actually looks like, or how that works. And I think it would do well to define that more clearly, so that if that is the lead ICD to the executive with overall responsibility for HAI, that it says that.
Yes.
So that it sets it in a policy or an SOP that is an accepted route of escalation.
Yeah, this might be an appropriate time to talk about something I was going to do tomorrow, but I think I'll do it now to save some time. Returning to this executive control group idea that Dr. Inkster had, perhaps I should just set it up for completeness. We had evidence of an executive group dealing with the decant. You reckon reading the minute of a meeting? You're nodding.
Yeah.
Yes.
Sorry. Yes, I did.
And we had evidence of the decision for the small-scale decant to the CDU from Ward 6A in early 2019 being discussed, at the very least by a stand-up in the ward with, or near the ward, with the chief executive. Do you have any comments, either of you, about the way that NHS GGC and these events around the Chahal unit dealt with the connection between the infection control doctor as the primary investigator and the people who made decisions about how the hospital should be run in the form of the executive group. Is there any balance of power issues, balance of information issues that you want to draw to our attention?
I think there was a very high expectation placed on the chair of the IMT without the associated authority to take action. And I'm not saying that the authority should sit there, but there was very high expectation placed on the chair of the IMT. And I think that maybe this, process framework will solve the problem. I think, it remains to be seen, but there needed to be a better escalation route then, which would have allowed the chair of the IMT to escalate in a much more formal way. And sending an email is fine as far as it goes, but it's not a formal route of escalation. And the ability for for instance, the review group that decided that they would do the decant from 2A, 2B into 6A, there was nobody from infection control at that meeting. Now, that's a really big decision, and if you're going to make a really big decision, you kind of need your subject matter expert to come along, brief that meeting, and make some recommendations in person so that they can be questioned. Whereas what you didn't have was any sort of subject matter expert as to whether or not this was going to work. And, maybe you should have had a clinician there as well who could have explained the risks to the patients and what the necessity
Because there was Mr. Redfern's paper, which looked at all the options.
But he's a manager, he's not a clinician.
What I mean is, are you saying that it would have helped to have someone like Professor Gibson
yeah.
and Dr. Inkster in the room?
Yes, so that they can explain the issue, they can explain their proposed solution, and they can be questioned so that the executive team making the decision can have assurance that they understand what the issues are. And sometimes it's very difficult to cover everything in a paper. So you might have a paper, but if you cannot interrogate that paper by having the subject matter experts in the room, it makes that really difficult. And it was a really big decision. And it turned out to be an even bigger decision than they thought it was going to be.
Because it was longer.
Because it went on for so long.
I mean, I've already asked you, and I think I'll come back to Mr. Dempster in a moment, but I asked you about the decisions in 2015 as if the two of you had been sitting in the shoes of people who were doing that event. So if I can ask you, Dr. Mumford, if you put yourself in the shoes of Dr. Inkster at the time of decant, now she's explained, if I recollect, that she was content with the solution because she thought it would be a short-term solution. Are you comfortable with the conclusion she reached? Or do you feel there's anything that needs to be said about whether it was?
I think
problematic.
I mean, I haven't seen the risk assessments that were done at the time. And, we know there was some delays because they had to do some work in the bathrooms and so on. So it's difficult to say. But if you just take the concept of should we decant this ward so that we can really get a grip of what is going on, then yes, that's an absolutely understandable decision. Where the best place to decant to, I don't know all the ins and outs of it, obviously, but it seemed to be, well, that's the easiest ward to empty, rather than this is the best environment or so on.
Can you help us about whether Because there's a view expressed that 6A is the easiest ward to decant, it's the easiest ward, it's nearby, it's in the building, it beats the alternatives because it's quicker than building a new ward in the car park, it beats going elsewhere because there's no access to ITU and all these things. I'm wondering whether you can help us on how much that decision to go to Ward 6A seems to be grounded in the idea that it's going to be quick or not very long as a decant.
I think that would have made the decision easier to make. To think it was only for a few weeks would have made a decision like that much easier. Because if you're thinking of a longer term decant, I think you would think harder about it and maybe it would change your risk profile.
Ms. Dempster, if I put you in the shoes of Mr. Vine at that point in 2018, do you have any views about the decisions she was involved in making around the decant and her support for it as an infection control nurse?
No, I think you would have been part of the process, that decision-making process, and then you as the IPC team would have been involved in assessing 6A, going to it, looking at it, what needed to be done, the standards. Things couldn't be changed, like the ventilation, etc. But I think it would be you would be there supporting once the decision's been made on how can you make this happen and how can you support the clinical team to move over as well.
So if we return back to the comment that Dr. Mumford was making about the informality of the of the management of Dr. Inkster through emails and those sort of reporting mechanisms. For both of you, is it reasonable for the executive side of the board to be the ultimate decision maker on whether you decant, whether you close the ward to admissions? Are these decisions something that it is perfectly proper for an executive board to make, or is it something that should be made by clinicians and infection control doctors? I wonder if you had any view, Dr.
I think that the executive team would make those decisions based on the information from the others. You know, I don't think any board would just say, oh, we're going to move across to ward, 6A tomorrow. They would have the information about that move from the IPC team, the infection control doctor, the, clinicians caring for the children. And they would be making their decision based upon the information they've received and assessed.
So there's nothing wrong, Dr. Mumford, about that decision being made by the medical director and the chief executive and the head of service and these people?
No, because it was a very big decision. And my feeling is that absolutely should not have been left to the chair of an IMT. That it had to be made at a higher level, and it had to be made at a level which would make everyone feel comfortable. So the executive seems to be the correct place, with the executive who has the HAI responsibility present for that decision.
Well, what I'll do is I'll return to this topic when we get to 2019, which we'll do tomorrow. It's now 20 to 4. I want to just deal with selection pressure and meropenem as the last topic before 4 o'clock. Now, you provided in your addendum report, which is bundle 21, volume 1, document 11, at 773. The next page, please. The section here about meropenem. And which of you is the principal author of this section?
Dr. Mumford.
Dr. Mumford. So you watched Professor Leonard's report evidence on this?
Yeah.
He has produced to the inquiry a paper by Aitken et al., which is published in which is yet to reach into a bundle. I think it'll make the 19th volume of bundle 27, but I know core participants have it. It's entitled Alteration to the Oral Microbiome and Cumulative Carbapenem Exposure Associated with Staphylococcus malaphilia Infection in Patients with Acute Myeloid Leukemia Receiving Chemotherapy. And you provided us with a paper which is in a bundle by Massip et al., which is in Bundle 27, Volume 17, Document 29. Oh, Aiken was there. Well, we've got Aiken on the screen just so we can see it and prove it exists. But we can go to Bundle 27, Volume 17, Document 29, page 336. Now, your report, your supplementary report, if we go back to that, so that is 21, Volume 1, page 774. I wonder if you can help us here, because I think for us who are lawyers, it gets very confusing. What is it that would have been seen at the time and would have been noticed at the time, or should have been noticed at the time, that would have been indicative of infections caused by meropenem resistance?
So I think everybody agrees that meropenem overuse produces a risk that you will start to select out meropenem resistant organisms. I don't think that is disputed by anybody. But what you tend to see if you start increasing the amount you use is that over time, and there is always a lag period, that you then start seeing your meropenem resistance creeping up. And then you reduce the amount of meropenem you're using because it can't be used as much because you've got a higher percentage of resistance. And then again, after that period of time with a lag, you will start seeing normal service being resumed and the resistance levels going down again. But that happens over a long period of time. So going up and coming back down. And actually the coming back down again is usually longer than the going up.
Right.
So, but that's not what I think happened here.
Well, if we were to look at the Harvey Wood graph, the one that prompted Professor Leonard's idea, as it were, which I think we can find in Bundle 19, Document 19, which starts at page 143. And if we can step forward and keep going. I think it's coming up soon. Please sing out. There we are. Is that it?
Yeah.
Yeah. So
No, this is
Totally,
use of
yeah.
antibiotics.
It's the next one.
It's not resistance. Yeah. There you go.
is that the one?
Yeah.
Right. Can you help us in looking at this graph to understand it, understand it correctly from your point of view? So what's your lesson that you're drawing from this? I recognise Professor Leonard's told us what he saw here. What do you see here?
Okay, so this is all numbers. It's not rates and it's not
Right.
percentages. It's all numbers. As I
And why is that a
understand
problem?
it. Because it's because the straightforward numbers of resistant organisms don't give you because you could have 3 Stenotrophomonas, which would skew your data, and it's not necessarily because they've been selected out. It's because that's what comes. If we assume that there's a water source, having 3 Stenotrophomonas in a quarter is because you've got 3 Stenotrophomonas in a quarter. It's not because they've been selected out by patients having meropenem.
So you need a rate per patient or per blood culture or per occupied bed days?
So you need a rate associated with the number of isolates that you have in that quarter.
It's a bit like a rate by positive blood cultures, but slightly different.
So yeah, so it's percentage resistance which is created by the number of resistant organisms divided by the number of total organisms isolated in blood cultures in that quarter.
Right, but this is just absolute numbers.
Yeah.
So what can this tell you?
So what you see is, so the solid lines with the triangles and the diamonds on are how much antibiotics you are using. So blue for Cipro, yellow for Mero, and blue for Tazocin, against the number of blood cultures. So DDDs for antibiotics means defined daily doses. So that's the number of doses that you were giving rather than the number of patients on antibiotics. It's
So some of them might have 2 or 3 doses.
some of them would have many more than that.
Right.
Yeah. So you'll see that there is a slight increase in meropenem use in the first quarter of 2018, but prior to that, it's reasonably level.
And that's the yellow line with the green squares. Green diamonds.
Triangles, yeah.
Triangles, sorry.
And then the dotty lines are the number of resistant gram-negative organisms. So this is the environmental organisms.
This is using the right-hand scale.
Yeah, no. Yes, sorry. Yes. So it's the number of blood cultures with a resistant organism in it.
So, for example, in early 2014, it's 2.
Yes.
Right.
And so you can see for both meropenem and Tazocin that fluctuates quite a lot, and it goes up and down. Now, if you had a high level of meropenem resistance, that would not fluctuate that much. If you would do it,
It would go up there and stay up there.
it would go up and it would stay up. And you can see across the bottom, you've got the purple diamonds, and that's the ciprofloxacin because you haven't got any resistance to ciprofloxacin amongst the environmental organisms. Oh, done something weird with my screen.
Yes, if you touch it, it doesn't like it. Effectively, is this chart showing that you're saying that this chart shows that there is a broadly consistent amount of meropenem use, and yes, there is an increase in meropenem infection gram-negative cultures in the second and third quarters of 2017, but there's a big reduction in the fourth quarter, and that is a no-no for a meropenem resistance. You wouldn't get that.
Yeah.
Right. Is there anything else you feel you need to add on this topic of meropenem resistance?
Well, in the paper that I wrote, I reworked the data that's in the.
If we go back to your paper, which is page bundle 21, volume 1, page. Thank you.
And put in the percentage of resistance.
Over the page.
So you can see the red line is the percentage of resistance.
So that's been added by you.
Yeah. So I've used Kathleen Harvey-Wood's data and just reworked it to show resistance rates.
So in a sense, that's the percentage of total blood cultures that are positive for meropenem resistant organisms.
The line, the red line.
Red line.
Yeah. So you see in 2015, quarter 2, you got 100% resistance because there was one positive blood culture and it was resistant to.
Right.
But that doesn't tell you that you've got a problem. That just tells you that you just happen to have a resistant organism. Yeah. And then as you go across, you can still see that the rate of resistance is fluctuating quite a lot.
But it's still there, isn't it?
It's still there, but then you would expect that. In most of these quarters, but not all of them, you had 2 or 3 Stenotrophomonas isolated. And they are always resistant to meropenem.
So they're skewing the data?
Yeah. So if you have, so let's say second quarter of 2017, when you've got 13 cases and you're running along at 40% meropenem resistance, that's equivalent to three Stenotrophomonas and maybe a cuprovidus or something, something
So you have
similar.
to check that against it.
So you'd have to go back and check against the log of bacteria, but it doesn't.
But you could check that against the case notes review report, couldn't you?
You could, and I could check it against the bacteremia data.
But without even going to data, with case notes review reports which years everything's in.
Yeah.
Right. Okay.
So there doesn't seem to be a problem with the meropenem resistance that is driving the organisms.
Are you effectively saying the meropenem resistance is being driven by the number of meropenem resistant organisms that are there because there's a water problem?
Yeah.
Right. Now, there are a few questions that I've been asked to put to you, but they may become irrelevant, but I'll ask them. Are you claiming that the only effect of meropenem is on fully resistant organisms?
No.
No. Are you oversimplifying the mechanism by which meropenem exerts a selective pressure, implying that only fully resistant isolates will then go on to cause infections in patients, and the situation is more complex than this?
No.
So does it matter for your conclusion that there is a range of different levels of resistance in meropenem organisms?
No.
Could it be that you've misunderstood either Professor Leonard's evidence or Dr. Harvey Wood's data?
I don't think so, no. I've gone back and looked at the transcript of Professor Leonard. I've gone back and looked at the transcript from Dr. Harvey Wood's, and I don't think I've misunderstood anything.
Okay. Now, if we go back to your addendum at page 775, we're there already. You are asked specifically to comment on the potential influence of meropenem on the acquisition of Cuprovidis pautulus infection. A study published in 2020 showed that only 8% of these isolates, of Cuprovidis isolates, were susceptible to meropenem, 74% resistant. In Dr. Inkson's publication on Cuprovidis healthcare water system, she found that only 1 in 5 organisms found in the system was susceptible to meropenem. Given that Cuprovidis is relatively common in water systems, the low pathogenicity, but in highly immunocompromised patients, is it plausible the selective pressure of meropenem and other broad-spectrum antibiotics was a contributing factor to a small number of these infections?
Well, there is a very small number of Cuprovidis infections, and I don't think that meropenem would have, meropenem usage would have, because it would be directly or indirectly through the environment acquired from the water, not as it doesn't form part of the microbiome of the gut. Therefore, there's no other mechanism apart from that direct stroke, indirect from the water through the environment into the patient route. So I don't think it would have any effect.
On the next paragraph, 2.9, you say, in the light of this high level of resistance, one would suggest that selection pressure by isoprene would contribute to Cuprovidis infection. However, this is highly unlikely given this. We just said that. So that's what is the evidence that, if we can go back to the previous paragraph. What is the evidence of this high level of resistance? No, I'm not going to ask that question. I think you probably covered it. Right. I think, Lord, this is probably a good time to peter out at the end of this chapter and suggest that we break for the end of the day?
We'll do that. We'll sit again at 10 o'clock tomorrow. That's appropriate. Well, it is appropriate. But we'll see each other tomorrow morning.
Okay, thank you.
Nancy, could you take this? And we'll see each other tomorrow at 10.